Hello, let's talk about preterm labor. So we're going to divide this up a little bit. So first we'll talk about threatened preterm labor. And this is often a diagnosis that we will see here, often a reason to be admitted or just to sit on assessment for a while. So this threatened preterm labor would be uterine activity and or back pain present between 20 and 37 weeks. So let's remember that cramping and contractions can feel like low back pain that comes and goes, and eventually it will circle around to the front and feel more like cramping and then take over your entire uterus. Lots of people will come in complaining of low back pain, and you kind of ask, does it come and go? And they'll be like, yeah, actually, it kind of comes back every 5 minutes. And when you put them on the monitor, they'll tell you, well, my abdomen, like my uterus doesn't hurt, it's my back, but you can see the contractions on there. So if you palpate to see how strong they are, as well as putting on the monitor, you might find that she's actually contracting when all it is low back pain for her. So threatened preterm labor would be uterine activity, but no evidence of cervical changes. This is a very common diagnosis, and it often leads to intervention when it doesn't necessarily have to. 1 in 5 pregnant women will exhibit signs and symptoms of preterm labor. 80% of women with these symptoms will not have a preterm delivery. So how do we treat this? We want to treat the cause. So what irritates the body is also going to irritate the uterus. If she has appendicitis, that will irritate the uterus. An STI, a urinary tract infection, pyelonephritis, this is a big one, and the gallbladder. So how do we treat it? So when somebody presents with threatened preterm labor, it doesn't seem like their cervix is changing, but they're definitely having something happening. We're going to do all this testing. We want to send swabs like for BV, trick, and yeast. Do a UA looking for any signs of dehydration or an infection, urine CNS, so that if she does have a urinary tract infection, we know what it is and how to treat it. We may do an ultrasound just to see how everything's going in there. Also an ultrasound looking for the appendix, which you're not going to see the appendix on an ultrasound because the uterus is in the way. And then a CT scan or an MRI to look at the appendix. We talk about bed rest and work restrictions. Bed rest, strict bed rest is no longer a thing because that increases your risk of DVTs, deep vein thrombosis. But we do sometimes ask people to take it easy. So it's not strict bed rest where you're laying in a bed and you can only roll side to side and use a bedpan. We don't do that. But we do tell people to take it easy. So there maybe you can't work 12-hour shifts because by the end of your 12-hour shift, you're always cramping. Or maybe you just need some work restrictions, like you need to do a desk job for a little while if you normally have a job where you're on your feet a lot. And then also hydration. This is one thing that if somebody's at home and they're cramping, they can drink a lot of water and rest, and maybe the cramping will stop. But if they're having cramping bad enough that they're worried, they should come here. Sometimes for us, it's as simple as giving them an IV bolus, fluid bolus, and then the cramping stops. So sometimes we will admit for observation. If it's convincing enough, we may give antenatal steroids. Tocolysis would be giving Indicid to stop contractions. We don't do that very often here anymore because it's not really proven to be super beneficial. However, if it's from an outlying hospital, you will often see that they gave Indicid because they want the patient to get here before they deliver, and then transfer to a center with a NICU, which is us. So criteria for discharge: if they've been asymptomatic for 24 hours, discharge to the city with a responsible adult and a ride to the hospital. So how does this affect our rural and remote residents? So sometimes we will have people that come to us from up north and they need to stay here in the city at minimum, if not in the hospital. So it used to be that they would stay in the hospital with us all the way until delivery, and that was a long time sometimes. Now with our prenatal home care program, if they are stable, we may be able to send them to a hotel in the community, or if they can stay with family or friends, and our prenatal home care nurses will check in on them daily or whatever is needed for them. And then if anything changes, they would just simply come back to us. So let's talk a little bit about what preterm birth affects. It's a major contributor to perinatal mortality and morbidity worldwide. Can cause respiratory distress syndrome, chronic lung disease, sepsis, cerebral palsy, blindness, and deafness. It is 9% of births in high-income countries, 13% of births in low and middle-income countries. In high-income countries, there's been no change in the incidence of preterm birth, but the rates are rising because of assisted reproductive technologies, complex maternal comorbidities, obesity, and advanced maternal age. Yes, we can get pregnant later in life. More and more people are choosing to do that because they want to be married or in a relationship or start their careers, or they started their careers and then a relationship never happened for them. And so they're getting later in life and they figure, this is my last chance to have a baby. All of that is fine, but it does carry risk factors with it. And when we talk about obesity and risk factors to do with obesity, if you think of it as a inflammation process in your body, it can affect multiple things. But when we're looking at just BMI, somebody could have a high BMI but be an Olympic athlete. They just have a high muscle mass. So BMI is only one indicator of health overall. But if we were to say, if we just looking at obesity as a whole, though, looking at it as an inflammation process, that helps to explain some of the events that can happen from that. When we talk about complex maternal comorbidities, well, with NICU care, we have been able to save many babies who were born with heart defects or other things. And now those babies are grown women and they are having babies. And with assisted reproductive technologies, people are getting pregnant that never would have been able to get pregnant before. So it is important to recognize for our families that the birth of a preterm infant is a situational and family crisis. Emotional and financial costs to the family and society are substantial. So we've talked about threatened preterm labor, which is uterine activity with no cervical change. Now we have preterm labor, which is uterine activity, regular or irregular, and cervical change occurring between 20 and 37 weeks. In 1982, the incidence was 3.6%. In 2009, 7.7%. Only 1 to 2% of all pregnancies deliver before 34 weeks. So we look at this pie chart. The bulk of there's a large amount of preterm deliveries in the 36th week. But 32 to 35 weeks is also a large amount. 28 to 31 is fairly small. 24 to 27 is smaller still. Those are your micropens. And then 20 to 23 is fairly small. So what are our causes of preterm birth? So there's PPROM, preterm pre-labor rupture of membranes, is 35%. Spontaneous is 45%. And then medically indicated. So these would be things like MC, MA twins, or your hypertensives that are so sick, we just need to deliver that baby. So what are our risk factors for a spontaneous preterm birth? If they've had a previous spontaneous preterm birth, they're at a higher risk of it happening again. Assisted reproductive technology, an antepartum hemorrhage, PPROM, cervical insufficiency, and twins or triplets. I like this chart. It shows if you had, for your first birth, a preterm baby, subsequent preterm birth, 17.2%. But if your first birth was not preterm, your subsequent risk is 4.4%. If you had, for your first birth, a preterm and second birth a not preterm, 5.7%. But what if you had two preterms before? First and second birth were preterm. Your subsequent risk is 28.4%. Other risk factors that we have: fetal anomalies, polyhydramnios, which makes sense. There's so much fluid in there and you're really stretching your uterus a lot. And it can only grow so big. Infections such as chorioamnionitis, a urinary tract infection, periodontal disease can cause preterm birth, current bacterial vaginosis with previous preterm birth, and malaria in developing countries. And if we think about malaria, we do have a lot of immigrants now that come from developing countries, and they may have malaria in their system. It's a parasite that lives in your liver and it can reoccur. Other risk factors are demographics, low socioeconomic status, single women and low education, maternal age under 18 or over 35. So when would we do an indicated preterm birth? This would be preeclampsia, complicated insulin-dependent diabetes, abnormal fetal surveillance, IUGR, intrauterine growth restriction, and placental abruption, chorio, and MCMA twins. How can we prevent preterm labor? So some primary ways to prevent it is smoking cessation, to quit using drugs, and addressing barriers to prenatal care. So when we talked about the socioeconomic factors, some of those were like single women, low socioeconomic status. That can affect whether or not you can get to your prenatal appointments. If you have a job where you don't have benefits, you don't get sick time, and you are pregnant and you're taking the bus everywhere, how are you supposed to get to your appointments? Or if you've got a bunch of kids at home and you're a single parent, there's no one else to watch your kids, and then your doctor's office says we don't want to have other kids at your appointment. For example, during COVID, lots of people, they just couldn't go to their prenatal appointments, and so a lot of them were over the phone. So if we can address barriers to prenatal care, that can go a long way to preventing preterm birth. Secondary things that we can do is screen and treat BV in women who have had previous preterm birth, and screen and treat for asymptomatic UTIs. So progesterone is a treatment that they do if you've been known to have many losses or to have preterm birth. They will sometimes do a progesterone treatment plan for you. It's only for singleton pregnancies with a prior history of preterm birth. They can give it as a shot, IM weekly. If it's a singleton without prior preterm delivery, but with a short cervix, sometimes they'll do a vaginal progesterone gel or suppository daily from diagnosis until 36 weeks. And a cervical cerclage sometimes. There's also a cervical pessary, and a pessary is a device that you would insert into the vagina. And this one is kind of round like that, and it would go around the neck of the cervix to help hold it closed until closer to delivery. So it's just a little bit less of an invasive way. But so what are some signs and symptoms of preterm labor? So your definitive sign is cervical effacement and dilation. Your subtle signs, low abdominal pain and or cramps, low backache, and pelvic pressure. So if somebody comes in complaining of those signs, we really need to take a thorough history and really listen to her. So how do we assess this? If they're under 32 weeks and we put them on continuous electronic fetal monitoring, we need to remember that your acceleration criteria is 10 beats above the baseline for 10 seconds. Do your maternal vital signs. You're looking for signs of infection. Consider pertinent obstetrical and medical history. For example, if somebody comes in and they are 33 weeks pregnant and they have cramping and low backache, and they had a previous preterm delivery at 31 weeks, I'm more concerned. And then we want to know about the pain. Where is it? What's the intensity and duration? Is it flank pain? Like, does she maybe have a pylo going on? Are there signs of a UTI? But keeping in mind that when people are pregnant, sometimes the signs of a UTI are masked. So we need to do a UA anyways, to make sure that there's not ketones and there's not loops in her urine. If you see anything concerning, then you need to send a urine CNS. So is there PV loss? Anything coming out of her vagina? So is it physiologic? Like, is it mucousy? Is it a mucus plug? When somebody is term and they come in and they're like, I think I lost my mucus plug, but they're not contracting or anything, like, I don't, that's great. I don't need to see it. I don't really care. But when you're preterm, if you've lost your mucus plug, I know that it can grow back, but that's also is telling me that something's happening in there. Is she bleeding? What color is the blood? Is it dark red or bright red? Is it a small amount or a large amount? Do you think it's just the cervix stretching and opening, which would cause some bloody show? Which, I mean, we don't really want that when she's preterm. Or is it frank red bleeding like an abruption? So amount, color, and odor of her show. Does she have signs and symptoms of a UTI? And signs and symptoms of vaginal and other infections? So we do have some predictors of preterm labor. Transvaginal sonography. So they can look at the mean cervical length of the cervix. The probability of preterm birth increases when the cervix is shorter, especially in women at increased risk of preterm birth or those with threatened preterm labor. We also have a test called fetal fibronectin testing for suspected preterm labor. Fetal fibronectin is a glycoprotein that's found in the extracellular matrix of the amniotic membranes. It's normally found in vaginal secretions until about 22 weeks gestation, and then again near the time of labor. It's released into the cervical vaginal fluid in response to inflammation or separation of the amniotic membranes from the decidua. So presence after 24 weeks is indicative of imminent labor. So this is a test that we can do as an adjunct to clinical assessment to diagnose and manage preterm labor. It's recommended for patients between 24 and 0 to 34 and 0 weeks gestation with signs and symptoms of preterm labor. The positive predictive value, the chance of delivering within 14 days with a positive test in women with symptoms, is 17 to 41%. However, the negative predictive value, the chance of delivering within 14 days of a negative in women with symptoms, is only 1 to 5%. So a positive, you can have a lot of reasons for false positives, but a negative gives us a lot of reassurance. So on ISP, under assessments, you can put in the fetal fibronectin exclusion criteria, and there's a list of questions here. So it asks you, is their gestational age between 24 and 0 and 33 weeks and 6 days? Are their membranes intact? Has she had a vaginal exam or intercourse in the last 24 hours? So that means anything in the vagina in the last 24 hours. If the answer is no, she can have this test. If the answer is yes, then we need to wait until it has been a full 24 hours. Has not had fetal fibronectin testing in the last 7 days, and does she have any vaginal bleeding? So to collect the sample, this is where they are kept in the supply room, but they are also in the back of assessment in the physician room at the back of assessment there. We need to enter the test through SEM and then tube the specimen to the lab. And you need to send it right away. It needs to be run fairly quickly. As soon as they get it in the lab, they run it right away. So let's talk about corticosteroids. So these are administered to women at risk of preterm birth between 24 and 0 and 34 and 6 weeks gestation. It reduces the risk of infant death, respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, respiratory support, NICU admissions, and systemic infections in the first 48 hours of life. The evidence on long-term effects is scarce. Routine use of rescue or repeat courses of antenatal corticosteroids is not recommended. Possible neonatal benefits should be weighed against possible long-term harm when considering corticosteroids at 35 or 36 weeks gestation. What we would give is betamethasone 12 milligrams IM every 24 hours times 2 doses. What are our nursing implications for preterm labor? We need to offer support, reassurance, and comfort measures. Monitor the fetal heart rate and contraction frequency using electronic fetal monitoring or intermittent auscultation as ordered. Always palpate the uterus to determine contraction strength. It does not matter how high or how low it looks on the continuous EFM. You need to palpate her uterus to know how strong that contraction is. There's no evidence supporting the use of intravenous hydration to prevent or arrest preterm labor unless she's dehydrated. Women with evidence of dehydration may, however, benefit from the treatment. So dip her urine for ketones and get a written order for a bolus. We often get people that come in on a long weekend and it's super hot outside and there's an outside festival. People come in cramping because they didn't drink enough. They were out in the sun all day and they didn't drink enough water. And so they come in here with threatened preterm labor. Those are the people who benefit from having an IV fluid bolus usually. So tocolytic medication, there is no evidence demonstrating that the use of tocolytics to arrest preterm labor results in a reduction of perinatal mortality. However, if they are at a peripheral hospital and they need to get here to the tertiary care center, they will often give them a tocolytic to get them through the ambulance ride, because we don't want them to deliver in the outlying hospital, and we don't want them to deliver in the back of the ambulance. We want them to make it here to Saskatoon. So the drugs used for this are indomethacin and nifedipine. The purpose, the goal of tocolytic therapy is to delay the delivery of the preterm fetus, allowing for administration of antenatal steroids, administration of magnesium sulfate for neuroprotection, and time for maternal transport to a tertiary care center. Tocolysis will temporarily stop contractions, but it does not remove the underlying cause of the preterm labor. So what are our contraindications to tocolysis? An abnormal fetal heart rate. We need to deliver. Lethal fetal anomaly, an intrauterine fetal death. Chorio, so an infection. Severe gestational hypertension with adverse conditions, and severe fetal growth restriction less than the 3rd centile. Indomethacin, gestational age under 32 weeks. It's not recommended above 32 weeks because it's an NSAID and it can cause premature closure of the ductus arteriosus, causing fetal death. Can also cause oligohydramnios if used over a long period of time. This is also why you're not supposed to take Advil in pregnancy or ibuprofen, because it can cause closure of the ductus arteriosus. Babies who are born with an open ductus arteriosus and it doesn't close on its own, the treatment that they give for that in NICU is ibuprofen to help close it. So that is why in late pregnancy, we don't want you taking Advil. The dosage for indomethacin, your initial dose is a 100 milligram rectal suppository, and then there is a maintenance dose that can be given. I personally have never seen the maintenance dose given, just the initial one. Discontinue use after 48 hours. So nifedipine as a tocolytic. This is the Adalat. It's a calcium channel blocker. It's a non-specific smooth muscle relaxant. It's also used to treat high blood pressure in pregnant and non-pregnant adults. The prerequisites for this is a patient under the care of an OB, written order, high-risk trained nurse, and nursing care of 1-to-1 or 1-to-2. Gestational age 24 and 0 to 34 and 0. Regular contractions, more than 3 in 10 minutes, with or without cervical change, and a normal or atypical documented fetal health surveillance. If it's abnormal, then we just need to have a baby. We should have a maternal IV in situ. So there is an antidote, which is calcium gluconate. And where is this kept on our unit? This is kept in our code cart in the top drawer, and also in all of our Pyxis machines. And we need to have baseline maternal vital signs. So we're not going to give Adalat if she has a systolic blood pressure below 100 or a diastolic below 60, or if the maternal heart rate is above 120. There can be a change in baseline of 40 or more for the blood pressure or heart rate. If the patient feels dizzy or syncopal, we probably should not be giving this drug. Over 34 weeks gestational age is another contraindication. A cervix more than 4 centimeters dilated. Hypersensitivity to calcium channel blockers. Antepartum hemorrhage, IUFD, abnormal fetal health surveillance, severe preeclampsia or eclampsia, or a chorio. Significant maternal cardiovascular disease, we don't want to give this drug. Maternal liver disease, any condition where the risk of prolonging the pregnancy outweighs the risk of preterm birth for mother or baby. Some relative contraindications is diabetes mellitus with end organ dysfunction, already used another tocolytic agent, or rupture of membranes. Your initial dose is 10 milligrams IR orally. The onset should be about 20 minutes with a peak in 30 to 60 minutes, half-life of about 2 to 3 hours. The duration of action of a single dose is up to 6 hours. If contractions persist, may be repeated every 20 minutes until mother has no contractions in 30 minutes. The max is 40 milligrams during the first hours, but ensure that there is no maternal hypotension. We should have her on continuous EFM when she's taking this, while the patient is having 3 or more contractions in 10 minutes. Blood pressure, heart rate, respiratory rate every 30 minutes until 1 hour after the last dose, then Q1H times 1, then Q4H for duration of therapy, and temp Q4H. She should remain under the care of a high-risk nurse for 24 hours, monitor for adverse maternal and fetal effects, and teach the patient about adverse maternal effects, what to watch for in terms of hypotension, how she feels, and report to nurse any symptoms. The maintenance dose is 20 milligrams every 6 to 8 hours for up to 24 hours. Then patient must be reassessed by the MRP. So what are your adverse maternal effects? What are we telling our patient to watch for? Nausea, flushing, dizziness, palpitations, headache, heartburn, peripheral edema, neuromuscular weakness, hypotension, pulmonary edema, atrial fibrillation, and rarely an MI. How do we treat maternal hypotension caused by Adalat? We can give calcium gluconate, 10%. It's a 10 gram, 10 mil IV every 5 to 10 minutes, up to 3 doses. It's not a standing order. You need to get an order. Call for help. Get the MRP or designate there. Intrauterine resuscitation as per normal. Repeated maternal positioning. And this does not mean turn to your left, turn to your right, get on your hands and knees. It means turn to your left and give that a chance to work. Now let's get on your hands and knees and give that a chance to work. If the cause of her low fetal heart rate is hypotension, well, what we really need to do is lay her bed down and give her an IV fluid bolus. And once her blood pressure comes up, the fetal heart rate will also recover. So tip her left and do those things and see if that fixes the heart rate. We only give oxygen if the mother's saturations are low. So throw a sat probe on her. If she's satting low, then yeah, she'll need some oxygen. Otherwise, if she's satting 99, 100%, well, the baby, you can't get higher than that to get to the baby. Okay, so let's talk about magnesium sulfate for neuroprotection. So the preterm neonate or child has a higher risk of dying in the first weeks of life. More preterm infants are surviving, however. Those that do survive have an increased risk of neurologic impairment, such as cerebral palsy, blindness, deafness, cognitive dysfunction and learning disabilities, and substantial motor disabilities. Prematurity is the #1 risk factor compared with infants born at term. So if they're 34 to 36 weeks, 3 times higher risk. 30 to 33 weeks, 8 to 14 times higher risk. 28 to 30 weeks, 46 times higher risk. And less than 28, those real microprems, 30 to 80 times at higher risk. So other risk factors: preterm delivery, very low birth rate, multiple gestations, demise of one fetus in a multiple gestation, maternal infection and chorio, PPROM, thrombolytic complications. What decreases the risk? Advancing gestational age, as in the further along in her pregnancy she is, the less the risk factors for these complications. Preeclampsia decreases the risk. Antenatal steroids decreases the risk, and magnesium sulfate decreases the risk. So let's look at this as a little bit. The correlation with magnesium sulfate as a neuroprotectant was noticed in the 1980s in studies of women with preeclampsia who delivered preterm. The first study to suggest a possible role for magnesium sulfate as a neuroprotectant was done in California and published in 1995. So the exact mechanism is unknown, but what they saw was that these people who had preeclampsia, we treated it with magnesium sulfate, and then those babies did better and less incidence of cerebral palsy and other things. So the proposed theories are cerebral vasodilation, reduction in inflammatory cytokines, reduction in oxygen free radicals, inhibits the calcium influx into the cells. So we don't really know what it does exactly, but those are our theories. So our maternal care policy. We want to consider using magnesium sulfate for neuroprotection when a viable preterm newborn is anticipated to deliver within the next 24 hours. 23 weeks up to 33 weeks and 6 days. If she's more than 4 centimeters dilated, actively contracting with or without PPROM, and elective preterm deliveries due to medical conditions. A magnesium sulfate infusion is a high alert medication and is administered according to our region-wide policy and procedure manual. So for preparation, we don't need baseline blood work unless there's other concerns. We need a main line of saline. It is compatible with oxytocin, but they are both high-risk drugs, so they have to be run on a separate pump. And I think best practice is probably to run them in separate IVs. We have pre-mixed bags that are 20 grams and 540 mils. So check the expiration date. It has a short shelf life of 60 days. You get this from the Pyxis machine. So first we give a 4-gram IV bolus over 30 minutes. It's on the Smart Pump magnesium obstetric load. The pump is preset for what our bags are mixed for, 20 grams and 540. The volume to be infused is 108 mils, and the rate is auto-populated to 216 mils per hour. We used to give a maintenance dose after the bolus. It's not routine anymore. The maintenance dose is 1 gram per hour. It's not routine, but maybe given per physician order. I don't think I've seen a maintenance be given for neuroprotection in a very long time. So what monitoring do we have to do when they're on mag-sulf? Like it kind of makes you feel crappy. So maternal blood pressure, heart rate, respiratory rate, and SpO2, Q15 times 1 hour. Then you would continue to do it every hour if the maintenance dose is infusing. The maintenance dose is normally infusing if she's preeclamptic. But if we're just giving it for neuroprotection, we don't normally have the maintenance dose. You want to notify the MRP if her respiratory rate is less than 12, because that would indicate magnesium toxicity. She should have continuous EFM for 2 hours, then obtain further orders. Decreased baseline variability is expected, and you need to weigh that against possible fetal distress. Rule out other causes and do your intrauterine resuscitation as normal. We also need to check her reflexes. In the setting of a hypertensive disorder, we're already going to see brisk reflexes. They will be absent reflexes with magnesium toxicity. The patellar reflex may be impaired or absent in the presence of an epidural. So when we're looking at reflexes, we rate them as 0 to +4. 0 would be flat or no response. 1+ is somewhat diminished or low normal. 2+ is average or normal. 3+ is brisk, more than average. And 4+ is very brisk, indicative of a CNS abnormality. I believe I have a slide coming up showing you how to do it. So side effects of magnesium: sudden skin flushing, sweating, dizziness or lightheadedness, drowsiness, hypotension, respiratory depression, muscle weakness, weak deep tendon reflexes, nausea, vomiting, shortness of breath, chest pain. So we want to keep an eye on these women. And if they, for example, need to get up to the bathroom, don't let them go on their own. You need to go with them. What is our antidote if we suspect magnesium toxicity? Calcium gluconate. IV, it's 10%. You give 10 mils and you can give it in a mini bag, or you can give it IV push. You will need to give it over 6 minutes, however, over 6 minutes. So the preterm fetus in labor has decreased oxygen reserves, therefore does not tolerate contractions as well as a term fetus. You will have more atypical or abnormal tracings, increased variables and severity of variables, more prone to tachycardia, and will have more late decelerations. This is what we expect to see in a preterm baby in labor. These babies are also normally have oligo. The fetus does not have the fluid to cushion it from contractions. So you'll see the increase in variable decels and late decels. There's a lack of development of the parasympathetic system. So you will have decreased variability in this baby. And this is why your accelerations for under 32 weeks are 10 by 10 by definition, because the parasympathetic nervous system is not developed enough to see those big accelerations. There will also be less tolerance for abruption and high blood pressure. There's an increased risk of malpresentation with preterms. Increased risk of cord prolapse because, well, often these babies are not head down. Also, the head might not be big enough to block off the entire cervical opening, and a cord can slip in there. And so with operative delivery, then they're at a risk for intracerebral hemorrhage. So we don't want to use a vacuum on a preterm baby. So there would be an increased use of forceps if we needed something to help us. Preterm pre-labor rupture of membranes causes an increased risk of PPH, chorio, and sepsis. You do not have to be fully dilated to deliver a preterm infant, especially under 30 weeks. So lots of caution with getting up to the bathroom. Labor assessment prior to ambulation. Do you feel pressure? Does it feel like you have to poop? So does she really have to poop, or is that the baby? Is it rectal pressure from the baby? 1-to-1 nursing care is required. Often these people will put a hat in the toilet just in case they get up to the bathroom and they deliver. And I don't feel comfortable being out of the room when they get up to go to the bathroom. So care of the preterm newborn. Delayed cord clamping is important if baby's well enough for us to do it. You want to avoid Trendelenburg, so avoid putting the head lower. They'll need some increased pressures for positive pressure ventilation to help open up the lungs. Sometimes they'll need some drugs for resuscitation. Handle them gently, plastic bag, and a hot shot. So if you'll remember from NRP, these babies, we're gonna have a heating pad underneath the mattress on our pandas, and then have a plastic bag there. So instead of drying this baby, you're gonna put them into that plastic bag wet and wrap them, and then do your treatments inside there, because we want to prevent them from cooling down too much. So if we go back for a moment to talk about reflexes, I think we may have taken the video out that shows how to do them. So you should practice this with somebody. But what you do is you find the tendon here, put your thumb on it, and then this arm needs to be dependent, like loose like this. And then when you hit your thumb that's on that tendon, their hand should do this. And that's how you would know that they have a reflex. If nothing happens, they have no reflex, and that's magnesium toxicity.